everybody. Lovely. Kathy, is that everybody in? Yeah.
It's incrementally, I'm adding people, but
okay.
Yeah.
We'll wait another minute. So. Okay. We might get started in the interest of time because we have a very busy schedule this morning for the National Health Advisory Forum meeting. So thank you so much, everyone, for joining us this morning on the 5th of December. Can you believe it? We're nearly at year end. My name is Emer Begley. I'm the Director of Advocacy in DFI, and the National Health Advisory Forum meetings, you'll know we generally have a briefing by an external expert who comes in, and it's really about an area of work that is an area of concern or interest for DFI members and for DFI staff. So today we're delighted that Dr. Carmel Mulani is joining us today. Carmel is the public health lead for Dublin South East Health Region. You'll know that the health service is going through a huge restructure at the moment, and we now have 6 health regions. And there is, you may have heard the term population-based approach, and Carmel's going to talk to us about that. What does that mean for people with disabilities? What does that mean for disability services? And while Carmel is based in one health region, she's going to talk more broadly about the approach that the health regions are taking with population-based approaches. Carmel's not going to be able to answer all our questions today, just that's a caveat, but she is a member of the executive in our health region, and she will take back the queries and questions that she has. She's also part of a network with other population health or public health leads in the other health regions. So it would be very important that she is aware of the questions and concerns of our members. And while she may not be able to answer every question, she certainly will take them back to colleagues who will, and we'll follow up with her after that. So just a bit of housekeeping before we get started. You'll see we have Catherine, who's joining us, and her colleague, who is the ISL interpreter today. So thank you to them. We are recording the presentation part of the session, and we'll turn it off for Q&A afterwards. So Carmel has a presentation of about 20 minutes. So I'd ask you to really hold on to your queries and questions until after Carmel's presentation. Thanks also to those who sent in their questions in advance, and I have those separately, and Carmel's had a chance to look at those as well, so she may respond to them during the presentation. This is going to go on for about an hour, I'd say. Carmel will present until about 25 past 11. Then we'll have questions and answers. And then I'm going to hand you back to Kathy, you'll all know Kathy, who's our health advocacy manager. And Kathy is going to do the business of the National Health Advisory Forum part of today's meeting, which is looking at our priorities, our health priorities for 2025. So before I hand you over to Carmel, I just want to tell you a little bit about her. I mentioned that Carmel is she's a consultant in public health medicine, and she's the Regional Director of Public Health in HSE Dublin and South East, as I mentioned, and she's based in Kilkenny. She's worked as a consultant in public health medicine and has a particular interest in health protection. She was Interim Director of Public Health in the former South East Department of Public Health, and she led the public health response to COVID-19 pandemic in that region. She led the development of the HSE National Framework for Self-Management Support for Chronic Conditions, which was launched in November 2017. And she co-chaired the Higher Education Institute's collaborative group, which developed a national undergraduate curriculum for chronic disease self-management support. And that's just some of your qualifications, Carmel. So I think you're very well placed to take us through where things are at with population-based health approaches within the health regions, and we can get a good discussion going after your formal presentation. So Carmel, do you want to share your slides there? And thank you so much for being with us here this morning.
Thanks. Very happy to be here, Emer. Thank you. I'm going to try and share my slides now. Just give me a second. Um, so, and I need to go into slideshow so that you can hopefully see them properly.
We
Okay,
can. Lovely.
great. And hopefully they'll move on as well. Is that moving on?
It is.
Yeah.
Thanks,
Okay.
Debbie.
Super. So, hello everybody, and thank you very much for inviting me to speak today. As Emer said, I've been in public health for a long time, but I also have a background of being a GP in the past as well, before going into public health, both in the UK and in Ireland, which I think helps my perspective, I think, when it comes to the wider domains of public health beyond health protection. So I'm going to start with a little bit about how health services are now organised because things have changed. So the HSE Centre, which used to direct the regions as to what to do, how to spend money, etc., now it's the health regions that have that power, and the REOs have the authority to make decisions for their regions. Within the regions, there are integrated healthcare areas. So you know there are 6 regions in the country now, 6 newly formed health regions, and within those integrated healthcare areas. So there might be 2, 3, or 4 integrated healthcare areas within the region. So in the South, Dublin and Southeast, which is my healthcare region, it reaches right down from parts of South Dublin down to West Waterford. And there are 3 IHAs within that, really newly formed. The IHA managers are only in place about a month. So this is all very new. Those are our 3 IHAs. This is just for information to give you a flavour of how this works. And the important thing here is that they incorporate both hospitals and community health services, including social care. Everything the HSE is responsible for comes under one IHA managers and one IHA manager, and that is a big change because previously hospitals were run completely separately to communities, and there wasn't any integration across other than with a lot of effort across hugely obstructive barriers that were inadvertently, unintentionally, but were there and obstructed integration of the services. So integrated healthcare areas are the operating unit now within the health region, and they serve a population of an average 300,000 and take account of varying geographies, population size, local needs and services. The focus of the IHA will be on the health of the population across the range of care provided, from living well at home to inpatient care across all stages of life. It's a geographic, population-based model which will build on the established community healthcare networks. So there are community healthcare networks within the IHA, so that's the even smaller building block. And they've been in place for a little while, but still in development really. And I should say the integrated service delivery model is still in development. It isn't clear what the structures below the integrated healthcare area manager will be. So many of you are used to perhaps dealing with the heads of service and disability and primary care within the CHOs. They still exist, but at the moment that's only until March, at which time there needs to be agreement on changeover to a new model, which will look different to what's there at the moment. But it's still in development, so I can't give you any certainty about what that will look like. But it does appear that what was dealt with by individual heads of service will change. So there might be more than one thing under an individual head of service or equivalent level under the IHAs. They may incorporate some hospital services as well as some community services. So this is what the regional executive management team looks like. So the REO is there at the centre, has an executive management team working to her or him in the different areas. You can see that there are 3 IHA managers in this particular one. This is ours in Dublin Southeast, but they all look very similar. These key positions across the middle in the dark green include a regional disability lead. Now, I have to say, I don't think they're in place in post in any region as yet. They're one of the last things to come on board. So very recently, we've got a regional clinical director, and they're starting to come into post in the other regions. The regional director of population and public health is the regional director of public health, which is myself. There's a director of finance, people, e-health, communications, and those are all in post. But again, very recently, just in the last month or so, there's estates and National Ambulance Service as well. There's a key person, the Regional Director of Planning and Performance, who has just, those interviews have happened and people are just will shortly come into post. And I'll speak a bit more about that role because it's very relevant to population-based planning. You can see as well there will be input from patient and service users within this purple box up here. There is to be a partnership council, regional voluntary forum and GP forum advising the REO. So these are not actually in place as yet, but they will be set up. So I'll keep going in the interest of time. So as I've said, the structure beneath the IHA manager level is not finalised and some key EMT posts yet to be appointed. The disability lead, as of the 19th of November, I went looking to find the job spec. It's still being worked through, has not been finalised, and advertising and recruitment dates are to be confirmed. So that's still in progress. The Director of Planning and Performance role will work closely with the IHA managers, National Planning and Performance Function and Population and Public Health to ensure an integrated approach to planning in line with the results of regional population health needs assessment. And I'm going to say some more about those, and informed by population-based resource allocation. Again, I'm going to tell you what that is. We'll have close relationships with the national and regional disability function to ensure a coherent and consistent approach to planning and performance management and integration across the full continuum of care. So you can see that the Director of Planning and Performance will be a key role, as well as the disability lead. So they will also work with colleagues to influence the wider system with regard to planning and performance improvements, those involved in providing health and social care and related services, the public and key agencies whose actions affect the health and well-being of the local population, i.e. Section 38 and 39's local authorities and others. So that said, I'm going to go on to population health and population-based planning. So health itself, a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity, is the definition that the WHO have given us. Population health then is considered to be a state of optimal physical, mental and social well-being within a community where everyone has a fair opportunity to thrive. And the concept of fairness is really important here because population-based planning has at its core addressing health inequalities. So there are many determinants of population health aside from health services. So we have everything from climate change, the natural environment, air and water, really key to health and have been for centuries. Drinking water is one of the key areas of work for public health, for instance, still. But also you have public administration and governance, public and social policies, epidemiological situation, transport, streets, etc., all impacting on health. And then as you work closer in towards the centre of the circle, food production, occupation, education, all of these things beyond the scope of health impact very strongly on health and healthcare. But in health and social care, however, we have a huge opportunity to increase the impact we have, and taking a population health approach to enhance how we work involves partnering with communities and sectors outside of healthcare to extend our reach. So just to flag that supporting a population-based approach to service planning and delivery, which aims to address health inequalities, is one of the 5 strategic objectives of the health regions. So this is something the health regions are trying to do. Okay, they're getting started, but this is a very key objective. What is a population-based approach to planning? Well, it's defined as a cohesive integrated and comprehensive approach to the assessment of health needs at national, regional or local level to support decision makers in health service prioritisation, planning and resource allocation. And it's orientated to the needs of the population, as distinct for one for everyone in the audience or whatever approach may have been taken sometimes in the past. Although there have been instances of population-based planning in the past, the idea now, though, is that it is the key approach that should be used. So the key principles of population-based planning are to use data and the direct input of the community to ensure prioritisation and design of services that meet the population's needs. And in this little diagram, you can see population profiling as the first step and health needs assessment then, which go on to inform the three prongs: population-based resource allocation, service design and redesign, and population health management, which are three slightly different things. But the desired outcomes are that there would be equitable resource distribution, aligning healthcare funding with regional population needs to reduce health inequalities or inequities, improved health and well-being, to enhance the health and well-being populations by addressing both clinical and social determinants of health, promoting integrated care across all levels, acute, primary, community and social care, reducing reactive demand, so shifting towards prevention and early intervention to reduce the demand for reactive healthcare services, and better value healthcare delivery, enhancing service delivery and resource management for better patient outcomes and cost-effective care. So these key outcomes are from a strategic framework for population-based planning, which is currently in draft. It'll be finalised sometime early next year. It's a national strategic framework, but it will inform how population-based planning is delivered at regional level and will ensure that it's a standardised approach across all regions. So population-based resource allocation, you remember, was one of the prongs of that fork that is informed by population profiling and needs assessment. So this is a funding model for health and social care planning that seeks to equitably distribute available healthcare resources according to population need to promote allocative efficiency and equity in both health outcomes and distribution of resources. So this aims to give each regional health area a similar opportunity in terms of health resources to respond effectively and efficiently to the needs of its population and meet objectives. So this has been developed mainly in the Department of Health and is likely to be quite high level in that regard, but will take account of population information and needs assessments at regional level. But the region then has the authority, or is expected to have the authority, to distribute in greater levels of detail addressing the needs within the region. So what has been done so far? So regional health profiles were developed earlier this year for each region, and these were published and presented to the REOs on their first day in office. So these are really just a starting point and used Census 2022 data to describe the populations in each of the health regions, and also produced was a comparative report between health regions. So further work obviously needs to be done. But just to say a little bit about these population profiles, because they can be used by anyone. They're available at the address there. That's a link. But if you Google HSE population profiles, it'll come up as the first thing on the search, the home page for the population profiles. So these give an insight into the population in each region. Sorry, I didn't mean to go forward just yet, including age distribution, sex, language, country of birth, ethnicity, deprivation index, which is a really key one for health, by small area level. So within the region, you can see for each community health network, which is a population of roughly 50,000 in each network. So there'd be 19 of those within the Dublin South East region, for instance. You can see for each of those, the population, the age distribution, the sex distribution, and deprivation, and a number of other indicators, already kind of collated and usable for planning. And these are available already to the REO and her team, their teams within each of the regions. So many additional parameters from the census are available in Health Atlas, which is also available, publicly available. And I'll give you the address for that at the end. These profiles will be core to prioritising and planning health services, and the detailed profiles and links are at that link. So I'm going to fly through these just to give you an example of information. So you have the full population, the size of the population, the percentage, and as you can see, there's a huge discrepancy between the health regions. Some have populations more than 1 million, some actually less than 500,000. So there are quite big differences. So that's the first thing in terms of resource allocation, and that's at the highest possible level, that there could be more equity in how resources are allocated, even at regional level. Population trends. Some areas have had huge increases in population for various reasons. I won't go into the details, but through migration, through different issues, populations have increased everywhere, but in some areas more than others. Disability is one of the elements measured in the census. So the percentage of population with a disability actually varies quite a lot across the different regions. And these divisions are community health network level. So you can go in and look at the percentage in your own area, community health network or region, and look at what percentage of the population has a disability. There's also data on carers, on general health, etc. Of course, it has the limitations of being a census question, but it's a starting point. Deprivation, and this is material socioeconomic deprivation, as measured by a number of indicators that are combined to give a deprivation index. So age dependency, very young, very old within the population, occupational class, so professional, managerial, or unskilled manual, education level, primary or lower versus third level, and unemployment. So these are put together to give a deprivation index for each community health network. And this is just an example of the Dublin and South East ones, which are the ones I know best. And you can see there's a huge difference across even within this region. So red is extremely disadvantaged. You can see that central Wexford, for instance, southwest Wexford, has a lot of extremely or very disadvantaged people relative to some of the South Dublin CHNs, which have much more skewed towards the extremely or very affluent or affluent. So there's an awful lot of detail in this. It's really just as an example. And there are at-a-glance population profiles for each community health network with maps to illustrate the deprivation at very small area level. This is 50 to 90 households in each little coloured area within this map. And you can see even in a very affluent area, there are still some areas within it with people who are extremely deprived relative to the rest of the population. So the next step, and I'm sure I'm probably coming to the end of my time for talking, but there's more work now being done on health profiles. So we are moving on from the census data to what's available within health. And there's work going on to develop sets of indicators, core data for different groups, including older adults, child health, underserved populations, and others. There's about 14 in total. One of them is disability, actually, and there's some work going on those at the moment. It's not complete, and again, it's a starting point, but it's to build a picture for each of the regions and the management and planning within the region of the picture regarding each of those general areas in their population. So health service utilisation data, including what assets, even from the point of view of primary care centres, hospitals, services, workforce mapping, etc., will be brought into this. The community voice needs to be part of it. I'm going to say a little bit more about that, as I know that's what you're very interested in. And scoping is underway for more detailed health needs assessments for migrant health at the moment. That's just the domains that are being looked at for these health profiles. You can see disability is in there, as well as mental health, older adults, and a number of others. There is a framework which has been developed, published June 2024 for Ireland for health needs assessment. You can look at that if you want to. There are 6 main areas within that. I probably don't have time to go through the details of what, why, and who, but you will have access to these slides. But essentially, health needs assessment covers a defined population. That can be anyone within a geographical area or people with a particular characteristic or health conditions. So it's quite feasible, for instance, to do a health needs assessment for people with disability or people with a particular type of disability or an age group or geographical region in relation to disability. I think some work is being done in the West, which is one of the health regions, on this already, but I don't have any details of it. And this is my last substantial slide, really. This is the population-based planning framework, which is in development. I referred to it earlier on. It'll enable standardization of how this is used in each of the regions. So you can see that demographic data, such as we get from the census, is in the top left-hand quadrant there, moving on to health service data, etc. And moving on to the needs assessment, analysis of gaps, finding out what's not there that needs to be there, short and long-term planning. A really key one is there in the right-hand lower quadrant, integrate with planning processes. And this is where that key role on the EMT, the planning and performance lead, comes into it. With the managers leading on population-based planning need to be linking in with the planning process so that all of this can inform requests or bids or decisions on funding and resource allocation. And then, of course, there's constantly monitoring and evaluating, review, and this will be a cycle over time, all very much in development. This is just about public health's role within this. We would generally be involved in health profiles, needs assessments, and pushing for the results of those to inform allocation of resources. And this is a link to the profiles landing page that I referred to, link to Health Atlas Finder and the needs assessment framework if that's of interest. So I'm going to stop there, and apologies, Emer, if I've gone a little bit over time, but I'm happy to take any questions now.
And Carmel, thank you so much. As you mentioned, the slides are going to be available to everyone, and we'll circulate them afterwards because there's a lot in it, a huge amount in it. But you brought us through it very nicely, so thank you so much. I have a few questions that were sent in already, but I'd like to open it out to everybody. If you just raise your hand and just state who you are and the organization you're with, as we didn't have an opportunity to do a round robin at the beginning of the session. So I just open it out there to anybody if you have a query or question. Don't be shy. I can take over this whole session now and just keep asking loads of questions. I don't want to have to do that. I don't know if it's a good thing or a bad thing, as Elaine, our CEO, said yesterday in another meeting, if it means that everybody just gets it, or it's too much for people to understand. But Elaine,
I think Liam has a question there. I see his hand up.
Great. Oh, Liam, thanks.
Sorry,
I can't see everybody, so Liam.
Put my hand up, piece. So apologies for that. Thanks, Carmel. Very interesting, and I'm very interested in this kind of resource allocation idea and the idea of equity. And I guess the intent is around reducing the negative association between, various, what's the word? So